This presentation summarises issues around the transition to Level 1 restrictions and what that means for regular dental practice. If we think about the situation at a global level, the rate of cases and deaths in Australia has been extremely low compared to other countries, as this comparison from Our World in Data shows. This tells us that the various restriction measures which were introduced in Australia were highly effective. Here we can see a plot of the number of cases reported each day, with markers showing when different types of restrictions were introduced. As a consequence of this, the number of new cases fell off quite dramatically from the middle of March to the present time. We think about what's happened in Australia in terms of restrictions and make global comparisons, we could say that it's actually been quite effective. Here is the Stringency Index score showing Australia at 71 points versus New Zealand, for example, at 100, where dentistry was shut down and a number of other restrictions were brought into place. If you track what has happened in Australia, the amount of testing which has been done is enormous by world standards, and the percentage of positive cases has been extremely low since late April. Were the restrictions in Australia effective compared to the more severe restrictions in New Zealand? Well, the answer to that is this simple plot which I have prepared by tracking the collated data on the deaths per million of population for Australia and New Zealand from the very first case on the 1st of March through to the present time. And we can see that the rate for Australia has been for most of that time lower than New Zealand, indicating that the restrictions which have been applied have actually worked extremely well and indeed could be considered a template for further pandemics in the future. The grand plan for managing the COVID pandemic in Australia is laid out in this document, the Australian Health Sector Emergency Response Plan for COVID-19. It's a publicly available document. The logic behind this document is to limit the impact of the spread of coronavirus on the Australian population and in particular its demands on the healthcare system, bearing in mind that the coronavirus which is responsible for COVID-19 is spread primarily through droplets that are generated when a person coughs, sneezes or speaks. However, transmission can also happen when we come into contact with a surface which has been contaminated with those droplets, and then our hands then touch our eyes, our nose or our mouth without having done hand washing or alcohol-based hand gel. The COVID-19 pandemic plan that I've just mentioned describes a series of stages. Towards the later part of the document, there's a description of the stand-down stage. And the trigger for this is when the advice given to the National Cabinet is that coming from the CDNA, the outbreak has reached a level where it can be managed under normal healthcare arrangements. This means that the number of cases occurring is so small that they can be managed easily within the existing healthcare system. There will also be, of course, monitoring for second waves and obviously a range of transitional activities. But the key thing to point out to you is that a number of the activities in stand down are the resumption of elective procedures in hospital and the resumption of non-urgent healthcare work. Well, clearly we have seen both of those things happen as part of the first stage of the transition back to the world post-COVID-19 under the transition scheme described by the federal government in the public media in recent days. Just focusing down onto infection control in dentistry, it's very important to understand what effectively could be considered a chain of command and how the different parts work together. The ADA, through its Infection Control Committee, has been providing advice, and the Infection Control Committee developed a document describing levels of restrictions and also the procedures that were necessary to manage COVID-19. Those core documents were aligned to make sure that they matched exactly the stages of the National Pandemic Management Plan that we've just described. Those two documents from ADA were endorsed by the Communicable Diseases Network of Australia, the CDNA, and then by the AHPPC, which effectively is the Chief Health Officer sitting together with the Chief Medical Officers from all states and territories of Australia. And that was then endorsed by National Cabinet. As a consequence of that, the ADA restriction levels and managing COVID-19 documents became the official requirements for dental practice during the COVID pandemic. And this has been stated on multiple occasions by the Dental Board of Australia, the regulator of dentists and dental students in Australia. During the pandemic, the ADA has produced multiple advice documents and flowcharts to help explain the levels of restrictions and to give practical advice. Here is the Dental Service Restrictions document outlining Level 1, Level 2, Level 3, 4 and 5. Fortunately, in Australia, we did not get to Level 4 or 5 restrictions, unlike some other countries. And here is the first page of the Managing COVID-19 Guide, the officially endorsed what to do during the COVID-19 pandemic for dental practice. I want to focus on just two elements of this because these remain current even now at Level 1 restrictions. And these are to obviously triage patients, have the patients do hand hygiene in the practice, and then to make the patient use an antimicrobial mouth rinse, of which there are different sorts, as you can see: dilute hydrogen peroxide, povidone iodine, chlorhexidine, and essential oils. If we think about the timeline as to how the ADA restrictions work, we can see that summarised here. The outbreak was noted in the Wuhan region in December, and it was reported to the WHO in late December. During January, it began to spread from China. In late January, I wrote an article which became an email alert that ADA put out, flagging that at the time what was a very small outbreak in China of less than 100 people may well spread more widely and have impacts, including on dental practice in Australia. Little did I know at the time how prophetic that would be. In February, the WHO declared a pandemic and we moved straight from no restrictions to Level 2, and then from the 25th of March, we moved to Level 3, where we remained for 4.5 weeks before coming back to Level 2 in April for just over 2 weeks, and then returning to Level 1. New Zealand went from Level 4 back to Level 2. It is very likely that we will remain at Level 1 for quite a long period of time. Some commentators suggest that that might be the case until there is the effective deployment of one or more vaccines against COVID-19, or until there is evidence of complete suppression of the disease using other measures. However, it's likely to be for quite a long period of time, hence it's important to understand what Level 1 actually means. Here is the decision tree for Level 1 patient management, published by ADA on the 8th of May. A key element is to continue the triage of patients by phone, so that patients who are unwell do not come to the dental surgery. This will, of course, also remove, by definition, not only patients who have COVID-19, who now are very few in number, but also remove patients who have viral influenza and other respiratory infections, because these patients will have coughs and fevers and other symptoms which will be picked up by the phone triaging system. This is an extremely good thing. Already in Australia in 2020, we've had over 20,000 documented cases of viral influenza. And in a typical year, we would have over 700 deaths from influenza in the community. Hence, continuing on with patient triage is very useful for the public health management of influenza, particularly during the winter months when the prevalence is much greater. So when the patient is triaged and they have no epidemiological and clinical risk factors, then they can be treated under standard precautions with the addition of pre-procedural mouth rinsing and the patient using alcohol-based hand gel or hand washing, as I've just described. combined with social distancing in the waiting room and limiting the number of high-touch items that can't be easily cleaned. For example, magazines and toys in the waiting room. That is the basic toolbox of measures that we are likely to be continuing during the rest of the 2020 calendar year. Then we have some additional scenarios shown in the red and the orange boxes. These scenarios will not be common. The patient who is known to be a current confirmed case. The patient who is high risk because of epidemiological and clinical criteria. And the patient who is a suspect case due to both epidemiological and clinical criteria. In all these scenarios, the action is to defer all treatment which is not urgent. And after waiting for several weeks, the patient will then be able to go through their illness and return to health. After which time, when they're no longer shedding the virus, they can be treated. In order to treat such patients safely, a range of transmission-based precautions are needed. And those are exactly the same as were the case during the previous restriction levels. And those are outlined in the red and the orange boxes. And they're explained in detail in both of the ADA documents. There's also further information on the mega site which ADA has built as a portal for information to the public and to dental professionals, including those who are not members of the ADA, providing detailed advice. Now I want to focus on just a couple of key issues. The first one is around personal protective equipment, PPE. So on the 8th of May, the Dental Board confirmed the advice that was issued from AHPPC that there was going to be a move to level 1. So then the question is, what PPE is required? Everything in infection control is based on an assessment of risk. So as we've just seen in the flowchart, the patients who have been effectively triaged will not have viral influenza and are extremely unlikely to have COVID-19. They'll also be doing additional measures such as undertaking pre-procedural rinses, which are known to reduce the amount of coronavirus and also other viruses by over 90 to 95%. So these are different protective measures used for every patient for every appointment. And this blanket of protection means that regular PPE is sufficient. Notice that during level 2 and level 3 for the urgent or emergency cases, there were additional layers that were added onto this because of the difference in risk. And that was probably best illustrated by the use of gowns. If we're doing standard precautions, then using the traditional gowns that we wear over our street clothes is sufficient. When transmission-based precautions are needed, as outlined in the NHMRC guidelines, that's when some specific additional gowns would be used. So for example, when dentistry was operating under level 2, disposable gown was used over street clothes. And this was done to contain the spread of infection. Bare below the elbows applied for non-surgical treatment in low-risk patients. But under level 1, normal PPE is quite sufficient. Many practitioners don't understand that the standard precautions that are used in dentistry for all patients outside of pandemics are actually much higher than what is done in all other healthcare settings. We actually do part of what would be described as droplet precautions in a hospital or other health environment because we wear a mask all the time. We wear protective eyewear all the time, and we wear gloves all the time. Those things are not done in all healthcare settings, and this has been the case since about July of 1985, when so-called universal precautions were introduced as a result of the HIV pandemic and elevations in the rates of blood-borne viral infections. Some years later, in 1996, when body surface precautions were added in, they were renamed to be called standard precautions, and what was called additional precautions were then called transmission-based precautions. This new terminology better explained the logic behind them. Standard precautions, we do hand hygiene, PPE, handling sharps, doing environmental cleaning, reprocessing instruments by using mechanical cleaning and steam sterilization, applying cough etiquette and respiratory hygiene, etc. for all patients, for all procedures, regardless of whether we perceive those people to be at risk or not. And this is one reason why the number of episodes of transmission of infection in dentistry in Australia has been extremely small. Impervious gowns are only required when transmission-based precautions are indicated as per NHMRC guidelines. So that's really only for the management of the high-risk scenarios for COVID-19. Now, determining whether or not the patient is high risk is not something which the average practitioner is going to be familiar with making a decision about. And the case definitions for this change all the time, every couple of days. And I'll show you in a moment where they're published on the Australian Health Department website. But the key point is when an impervious gown is required to treat someone who is, for example, a proven case of COVID-19, it's not the only thing which is needed. That's combined with full airborne precautions, which means a professionally fit tested P2 N95 surgical respirator and a negative pressure room, things that aren't going to be practical in many dental practice environments. Now on to the issue of case definitions. These change very frequently, as you can see from today's version that had been updated several days previously. And indeed, all of these types of documents have got highlighted areas, so you can see how the case definitions change from day to day as we move through the pandemic. So the current version as of today spells out that a confirmed case is someone who's had the molecular test to show that they have the virus, or the virus has been identified by culture or by electron microscopy. It does not mean that the person has had a finger prick test from blood that takes 15 minutes. That test is a test for antibody to show that someone has been exposed and had the infection previously. It does not indicate the person is currently infected. Then note the definitions of probable cases and suspect cases. People have to meet both clinical and epidemiological criteria, not just one or the other. They need to meet both. So here are the clinical criteria: high fever, history of fever or respiratory distress, sore throat, etc. And epidemiological criteria, the close contact, perhaps being a healthcare worker, working in a frontline setting, etc. So the whole concept is that the risk is assessed based on those epidemiological and clinical factors. The epi factors will reflect what's happening at the local community level and what's happening in the state. And this is very important as social isolation restrictions are gradually eased. Also important that we recognise that there are patients who are more at risk of adverse outcomes, not only from COVID-19, but also because of viral influenza. So the measures that are being applied as part of level 1 restrictions in COVID-19 are actually a wonderful thing because they reduce the opportunities that will be there to spread around other respiratory viruses, such as adenoviruses, other forms of coronavirus and human influenza virus over the coming months. To get more information on current cases of COVID-19, there are a range of different tools. For example, in Queensland, the state government publishes daily updates by region showing the number of active cases and the total number of cases that have been diagnosed, and the hyperlinks are provided here. The Guardian newspaper also provides a locality map of the total number of cases, but this doesn't show the number of active cases. Here is a screenshot showing you today's data for different regions in Queensland. We can see, for example, there are no cases in Central Queensland, Central West, Darling Downs, Northwest, Southwest, Torres Strait, and Cape York or Townsville. And there are some active cases that are present in, for example, Metro South and Metro North. Here is an example of the information from the Guardian newspaper, which just shows where the cases have been. Notice how it tends to be a surrogate of the distribution of the population, and that's generally true for the most populated areas. And of course, Queensland, being a highly decentralised state, shows this sort of scatter up and down its seaboard. So this is a useful way of understanding where the disease has been, whereas the state-based data, which is updated every day, is a good way of knowing where the cases are now. Over the coming months, there's going to be more advice as the situation continues to change, and hopefully it will ease as the number of cases eventually drop to zero. It probably won't be until that happens nationally and is sustained for some weeks that there'll be some serious thought given to reopening on a limited basis initially some international borders. It's important to understand that all these things that I've described to you are planned out. Governments plan responses to pandemics well in advance. And there are health professionals whose whole life is based around the planning for pandemics and educating people on how pandemics are managed. And one reason why that's so important is that when pandemics occur, they can have dramatic impacts. Some previous pandemics have killed over 50 million people. Fortunately, the COVID-19 pandemic hasn't been anywhere near as severe as some of the previous pandemics of, for example, influenza, which have been experienced around the world. But the measures that we're applying now will also be useful against those sorts of infections. So consider what we're going through in level 1 and what we've been through in some of the earlier restriction levels, a wonderful learning opportunity that will no doubt serve us well later in our careers should there be another pandemic that we have to face.